And I'd like to thank Dr. Bharti sir. We've been doing this course for a long time and really enjoyed this. It's one of the longest courses I think I've been part of. The biomarkers in understanding etiology of ectasia, these are my financial interests. I'm not going to go too deep into this slide, but what it just says that there's a huge amount of interaction between what happens from the outside world and what happens in the inside world of corneal tissues. So how does it really affect us? When you look at post-LASIK ectasia or any ectasia, one of the major factors which comes to mind is the power of eye rubbing. And we have started looking at why do people rub their eyes? It's not that they have a kind of fetish just to rub it, or just that there's something happening. One of the things which clearly finds a role is the role of IgE and how it impacts your eye rubbing. And we have made this algorithm, which is all these papers are freely available on IGO, looks at all the allergies which kind of triggers it to make the person have a mild sensitization to rub. And a higher level of IgE, we even look at treating them with a slit therapy like sublingual immunotherapies and all that, to stop the eye rubbing completely, and that stops the progression of ectasia, both post-LASIK and pre-LASIK. So this is how we look at serum IgE less than 300, look at a lot of topical medication for that, more than 300, get an immunologist's opinion, patch test, desensitization, their avoidance of allergens, desensitization with sublingual therapies. And we have to probably think about topical immunotherapies for them before we do cross-linking. And this is just what I just explained. Ocular surface inflammation has been very predominant in post-LASIK ectasias also. This is a paper we published. This is how a post-LASIK nerves heal, and the post-LASIK no ectasia and post-LASIK ectasia. If you look at the nerves are completely fragile. And when we looked at the markers, when we looked at what those tears contain, it's like a small kind of a cytokine storm, like a picture there, with a huge amount of unwanted inflammation, which may be driving the cornea weak. These patients do complain of OSDI change, and you can see that a lot of this OSDI have been associated with dendritic cells and other parameters. We also have issues related to genetic markers, which looks at, we published this work where a stored lenticule, we were able to pick up a gene which was defective in a patient who developed ectasia. We call it a Lysol oxidase. Now, why is it important and how does it impact our management? First thing we have to understand is the relationship between collagen and inflammation. If you understand that, then it helps us to really think about giving a very proper level of treatment. These are the collagen structures, what I'm seeing, and this areas of these entangled structures or enzymes called Lysol oxidase hold the collagen tighter. We did an experiment where we had the same kind of collagen from the cornea, and we started, inducing inflammation. Once you induce inflammation, we started seeing that the collagen structure became weaker, just like how you would see it in a keratoconus. Now, what is interesting here, this is a Western blot analysis of that. The Lysol oxidase is these structures here which holds the collagen, and this is a collagen 4, 5, and 1. When you induce more of inflammation, like an MMP9, when this inflammation increases, the Lysol oxidase drops down, the collagen drops down. That means that more the inflammation drop is on the structurally, it drops the collagen and the Lysol oxidase. That means you don't need to rub, just the subclinical inflammation is enough. And this is what I feel happens in post-LASIK ectasia, because you end up in having poor corneal nerves, more inflammation, more cytokines, improper healing, and this would induce changes. And patients who had habit of again rubbing, it's like a double whammy effect. And of course, added to a genetic changes. So this is in keratoconus, not post-LASIK ectasia. In a subgroup of these people, because we had this experiment with us, we published this in IOBS in 2015, where we looked at using cyclosporin to see if it can stop it. And we were quite surprised about the number of patients who were it was able to stop and from progression. This is a very interesting study, and we still continue to do it before we do any cross-linking. Hormonal balance has to be looked into when you're looking at post-LASIK ectasia, but that's not the only one. Thyroid diseases combined with hormonal changes is a very important factor to cause ectasia. Thyroid is a very important factor which needs to be kept in mind. The nutrition, again, one of the major areas of my interest has been vitamin D, and vitamin D, B12 has been implicated. Vitamin D has been implicated even in COVID. Patients who had severe COVID in ICU, one of the major factors they found was vitamin D. And this, again, in a lot of our patients, including post-LASIK ectasia patients, is very low. So it's again like one more factor to be looked at when you probably need to treat them. And treating them is very important before even you think about a cross-linking or any of these procedures. The question always comes is, when do you cross-link? Because once you see a post-LASIK ectasia, first of all, you're feeling very sad because you feel that you've missed something. But you may be having a perfect topography, but you may have had so many of the changes which have absolutely no control with you, like wound healing, the corneal nerves, and all those factors. Just to summary on this, I always look at the IgE before I even think about cross-linking. I take care of the vitamin D. I give them time. I give them time for it to settle down. Every time you see an ectasia, there's no need to jump and do anything on them. Take care of their dry eye. Take care of OSD eye if it's high. Take care, if it's a meibomian gland dysfunction, take care of its steroids. Trehalose works very well with them because it changes the relationship of MMP9 and Lysol oxidase. All this has a huge impact in making it more stable. Which is the most ideal procedure? When it's progression, when you're 100% sure it's progressing, then probably cross-linking. I use a Dresden protocol here. And when your quality of vision is poor, then you can look at intacts of cross-linking. But when it's stable, try to at least give them time for a year, even though you see a patient coming to you with ectasias. And the inferior cone works wonderfully well. And post-operatively, you can look at scleral contact lenses or an ICL at the end of the procedure. For me, single cone inferiorly is probably the best. If there's one indication for me for intacts today, it's for post-LASIK ectasia. And post-op, again, I look into all this. I use some kind of a copper supplements. Copper is necessary for collagen and Lysol oxidase synthesis. So it I don't know how much it really helps, but at least you have something. So why not use this? So that is one of my ways of looking into this. This is an important question. Should we cross-link everybody who comes to you with post-LASIK ectasia? To answer this, we've been studying this a new technique called polarization sensitive OCT, which starts looking at your collagen fibers. This is an electron microscopy picture. This is the darker is your central region. The periphery is your fibers here, which is different in color. Most of the post-LASIK ectasia patient, if you just remember this, the darker blues are normal, the peripheries are in different colors. And this is how a normal cornea should look. Look at the post-LASIK ectasias. You can see that all post-LASIK ectasias do not look the same. Some of them, after 7 years, 8 years, 10 years, who just show on topography as post-LASIK ectasia, still look the same as a healthy eye. Look at the healthy eye here. And some of them, for example, this one, who is a post 9 years one, may be a little different because look at the blues are different. But this topography here may not progress. And if you operate on this kind of patient, you may end up in a more scarring because healthier corneas you cross-link, they end up in scarring or excessive flattening. So post-LASIK ectasias may on topography look scary, but all of them may not progress. And this is the kind of work we are doing. So that's why I said, give time for at least 6 months to 8 months. Only if it progresses, do it, because many of them, they might have self-aborted itself. And this is just a simple comparison of, again, the same slides, what I wanted to share. Thank all my team for this, and thanks Sudhank sir, and all the people, all my friends, Dr. Rishi, Dr. Ashu, for inviting me again.